Yes, so on behalf of the Barwon Health Foundation, my name is Francis Trainor and we thank you for all joining us today. Please let me start with the acknowledgement of country. We, the Barwon Health Foundation, acknowledge the traditional owners of the land, the Wadda Wurrung people of the Kulin Nation. We pay our respects to the elders, both past and present. We thank the traditional owners for the custodianship of the land and celebrate the continuing culture of the Wadda Wurrung people, acknowledging the memory of honourable ancestors. And we also welcome all Aboriginal and Torres Strait Islander people joining us this afternoon for our webinar. So welcome, ladies and gentlemen, to Barwon Health Foundation's Legacy Month and to our webinar this afternoon. As we know, we're all currently being affected in some way or another by this hideous virus that's within our community and right around the globe. But we do sincerely appreciate that so many of you have taken the time to join us this afternoon. And speaking of being busy, our healthcare heroes are not only busy but working and shining under extreme pressure right now. And this afternoon we're joined by our special guest, Barwon Health consultant, cardiologist, Dr. Kate Rankin. And we're really grateful, Kate, for you allowing us your most valuable time today. And we look forward to being officially introduced to you shortly. Today is being run as a webinar, so you can only see myself, Chair of the Barwon Health Foundation Bequests Committee, Jack Ayerbe, who I'll introduce soon, and our guest presenter, Dr. Kate Rankin. So that means we can't see you, but you'll be able to participate, and we encourage that by clicking on the raise hand button towards the bottom of your Zoom screen, and we'll try and unmute you and get your question for our guest speaker following her presentation. Alternatively, you can type in a question by clicking on the chat box. So while we're going through the formalities here, you might just have a little bit of a play around and see where those buttons are. And think of some questions you might like to ask Kate. As I said, August is Legacy Month, and it's coming right at a time where, under the backdrop of COVID, people are getting their affairs in order. Some are having their wills prepared for the first time, some are reassessing arrangements that they may have had made in the past, and many are thinking about their legacy, and importantly, how they can contribute to make the world a better place. There's strong evidence that people are making or amending their wills right now. A recent report showed that the number of sales of online kits have increased by 265% in the past few months in Victoria over the same period in 2019. The strongest annual rise was in the 65 plus age bracket, which saw an 8-fold increase. Now, some of you might think that this age group are more sensitive to their mortality and planning, but perhaps it's probably surprising to learn that in the report was that the 18 to 24 age bracket saw the second highest annual increase, with 7 times more will kits purchased recently compared to the prior corresponding period. Now, I know that some can feel a little uncomfortable in talking about wills. I guess because it involves death, but I think that just shows great common sense, and it's a wonderful this planning is being done by all ages. The other interesting statistic is that if people are asked if they wish to leave a gift in their will to a charitable cause, the numbers actually double. At Barwon Health Foundation, we strongly believe that there's no better cause than a consideration to getting the gift of good health. We too have seen a spike in recent giving in terms of living legacies and named funds, and those are donations now that are placed into an endowment to provide sustainable support for Barwon Health services. We've also seen an increase in memoriam gifts, donations of legacy in memory of a loved one, and gifts and wills. And it doesn't matter how large or how small the gifts are. There are so many wonderful examples, including a great number of people who have purchased a leaf, either for themselves or in memory of a loved one, for $500, $1,000 or $2,000 on our lasting legacy tree. We've also seen major gifts that have now been placed into named funds of individuals and families as living legacies. And there are so many great stories of giving, amazing bequests like that of Beth Allerton, whose gratitude was not just for the care she received personally at a hospital, but also as a gift for the community who supported her local business over many, many years. I'm not sure if many of you remember Allerton Shoes with a slogan of "For Women with Discerning Tastes." Beth Allerton's gift was directed to the Andrew Love Cancer Centre, and in gratitude, Barwon Health named the new oncology pharmacy in honour of the Allerton family. Another recent wonderful bequest was from a local pensioner, Archie Howard, who made a living as a concreter. Archie was a humble man who passed away late last year and decided in leaving gifts to those that were close to him that the hospital and the community were equally deserving of his bequest. Archie's legacy will care for patients and will save lives. And in terms of in memoriam gifts, no matter how large or small, they can make an enormous impact. And speaking of an enormous impact, some of you might have heard or read of the recent gift from the Costa family in memory of the late Adrian Costa, who died tragically together with his wife Mary almost 48 years ago in a car accident. The Costa family have made an inspiring gift to our community, funding the establishment of regional Victoria's first medical research clinical trial centre at Barwon Health. The research will bridge the gap between what can be provided in regional Victoria with world-leading, life-saving and life-extending clinical trials. Quite extraordinary. And another family recently made a donation in memory of a departed family member, which will now go to fund aged care beds at the McCullough Centre. Just so heartwarming and wonderful acts of generosity and care for the vulnerable in our community. But none of this community giving is new. In fact, Geelong Hospital was built on a legacy of giving from its early days in the 1840s, when a committee was formed by the Reverend Andrew Love, a name familiar to most of us, the name given to our cancer centre, to fundraise for a hospital in the Geelong community. They worked hard raising money, then they received a bequest, our first bequest, which Jack Ayerbe will tell us about shortly. So if you'd like any more information on how you can make an impact, either right now or in the future, please give us a call at the Foundation. We'd be happy to have a confidential discussion with you. And also, I'd just like to let you know that during Legacy Month, you can get your will written for free by one of our prominent local law firms who are donating their services for the good of the community. Now, please let me introduce a proud member of Geelong community who has that wonderfully strong social conscience and belief to give back to the region that he loves. He's a well-known, respected and loved community member who's involved in diverse areas beyond his occupation as a vet. His passions include animal welfare and the fascinating science and research into One Health, which recognises that the health of people is connected to the health of animals and the environment. And if we've got time at the end of the webinar with Kate, we might ask Jack a few questions about One Health and COVID-19. For many, many years, the Foundation was privileged to have Jack's contribution as a member of the Foundation Council. He's also involved with a group of fellows who, up until restrictions came into place, met every Tuesday for lunch, sometimes perhaps a long lunch. They go by the name of the WAWSO. That's W-A-W-S-O, standing for We All Were Something Once. Now, that group includes the wonderful Bob Eadie, who I can see is also tuned in today, and another fine man, Mike Fairweather. And I can tell you that unlike their acronym, they are absolutely still something. Off their own bat, they have conducted a couple of fundraising dinners and are well on the way to fully funding a PhD scholarship in important cancer research right here at University Hospital Geelong. And if that's not enough, the three of them are also members of our Bequests committee. So a big thank you to Bob, Mike, and of course, Jack. In addition to all that, Jack lends his hand as chair and ambassador to the Bequests and Malloy Society. Now, Jack has been in hospital over the past week having his hip surgery. In fact, he's still in rehab, but such is the quality of the man, he didn't want to let us down today. Would you please give a virtual big hand for Jack Ayerbe? Over to you, Jack.
Thank you. Thank you for saying such a lovely thing about our lunch group. We're really just a bunch of drunks who decided to do something more than just drink all the time. And it's been a great experience. About 160 years ago, this chap, Tim Malloy, who's a shepherd, was roaming the hills, probably on the outskirts of Geelong. On a hot February day in 1849, Tim was tragically bitten by a black snake. And unfortunately, then there wasn't antivenin available. And as he was dying, he wrote his will on a scrap of paper, and he left his income of 12 shillings and sixpence per week, his home in Britannia Street in Geelong West, and all his possessions to the much needed Geelong Hospital that would be built as soon as enough money was raised. Now, this will was witnessed by his boss, a first settler and landowner, John Cowie. I assume that's where Cowie's Creek comes from. And the first ferry bequest was received by our hospital. Just a few months later, Governor Latrobe visited Geelong and granted the present site, bounded by Ryrie, Bellarine, Little Ryrie and Swanson Street, as the place considered to be a hospital. Events then started to move quickly with an appeal for private donations and subscriptions, and it was the Geelong Advertiser that was a key player in this appeal, publishing all the results. The appeal was run across the district through schools and churches, and the Victorian government was also asked to contribute £1,200 to match the contributions raised quickly by the community. The rest, they say, is history. But it's difficult to see how the hospital could have been built without the Reverend Lavender Love and his committee, without the wonderful community, and without the likes of Tim Malloy. So we're inspired by Tim and many, many people over the last 170 odd years who have followed in his footsteps and given generously to our health service to ensure that we can provide the very best possible care and health service for our local community. You know, I talk to my friends in Melbourne when anyone asks me if I'm having anything done. And believe me, I've had a lot done over the years, repairs and God knows what. As I'm now 74, I'm having more. But I say we are very lucky in Geelong because you're going to get crook. Geelong is the place to get crook. We are privileged to have one of the highest standards of medicine in this country. Now, so what is important is we need to keep this going for our children and our grandchildren. And it won't happen with government support. Governments are running out of money to give to health. So we need to make sure that this high standard is promulgated and continued and indeed improved. And that's why it's important to have the Bequests Society. So if you are good enough to give a bequest in your will and you let us know, you then become a member of the Bequests Society, the Tim Malloy Society, and we have various celebrations throughout the year, including functions such as this. So just as our healthcare heroes do for us, we can also leave a lasting impact in giving the gift of good health and can also help save lives. So that is what the Tim Malloy Society is about. Now, Dr. Kate Rankin is a consultant cardiologist. That means she does hearts, with dual subspecialty training in echocardiography and advanced heart failure. She graduated from Monash University in 2008 with honours. Makes me feel old because I graduated from Melbourne University in 1969 and completed a cardiology training at University Hospital Geelong and then the Alfred Hospital in Melbourne. Kate then undertook 2 clinical fellowships at the Peter Munker Cardiac Centre at Toronto General Hospital in Canada from 2017 to 2019 in echocardiography and advanced heart failure and transplantation. During this time, she performed a large volume of complex echocardiography cases, including stress and transesophageal echocardiography, which is published in major cardiology journals and presented research at international conferences. She also gained extensive experience in the management of advanced heart failure, including mechanical circulatory support and cardiac transplantation. But Kate hasn't started yet, she's just beginning. So please welcome Dr. Kate Rankin. Thank you, Kate.
Thank you very much, Jack, and thank you very much to the Barwon Health Foundation for the opportunity to speak. I'm truly thrilled. I'm just going to try and get my slides up for everyone to see. Are they working there, Francis? Excellent. So I've been asked to speak to you all today about a subject that's obviously very close to my heart, being cardiac disease. And I sort of wanted to paint you all a picture of how, despite significant advances that we've made in the last 50 years, heart disease still continues to be the #1 contributor to health disease burden and death in the Australian population and the population throughout the world. I'm just going to make my slides here. So just a few statistics for you from Australians' point of view. So coronary heart disease, so heart artery disease, is still the leading cause of death in Australia at this point in time. And it represents 1 in 5 deaths in all Australians. Cardiovascular disease in general, so this encompasses both heart artery disease, stroke, encompasses 1 in 4 deaths in all Australians. And the really key factor that I want to drill home to everybody today is that a big percentage of our risk of developing cardiovascular disease are all contributed to conditions that are largely preventable and treatable, particularly diabetes, obesity, high cholesterol and high blood pressure. 2 in 3 Australians at the moment are overweight or obese, which is one of the leading risk factors for heart disease still. And because of the significant burden in the community of cardiovascular disease, it significantly contributes to our overall health burden. So 19% of the total disease burden in Australia is contributed to by cardiovascular disease. Indigenous Australians in particular are an at-risk group, with them having a much higher hospitalisation and death rate compared to non-Indigenous Australians. And hospitalisation rates are also 30% higher in regional and remote areas of Australia compared to metropolitan areas. As I mentioned before, it contributes to 1 in 5 deaths in all of Australians. So that equivalates to 1 Australian dies every 9 minutes from some form of cardiovascular disease, or 76 deaths per day from coronary artery disease. And we have on average around 1,100 people admitted to hospital in Australia for some form of complication from cardiovascular disease each and every day. And this is just a sort of graphic here that we're talking about a large percentage of Australians that are living with cardiovascular disease. That really is an umbrella term that encompasses several things that I'll talk about in detail at the moment. But the main thing to sort of appreciate is that it still continues to be our leading cause of death in Australia. And as you can see from this graphic, and I thank my colleagues at the Baker Institute for this lovely representation here, but there have been huge gains made in general cardiovascular health and outcomes after significant events such as heart attack or stroke over the last 50 years. But of significant concern, these improvements that have had this nice sort of general down trend of our death rate have really plateaued out over the last several years. This is 2016 data. And the concern with that is, are we entering a period where we're becoming complacent and not aggressively managing things as best we can to continue that downward trend? And one must worry that, does this period of complacency or plateauing out represent that cardiovascular disease may be on the uptrend in the future? And there's a lot of things that contribute in this current day and age, how much of a significant impact cardiovascular disease has, both on the health of the general population and also on the burden of disease in Australia and burden on hospitals. Particularly, as we know, we have an ageing population. So with increasing life expectancy and an ageing population, there will be more and more patients requiring hospital admission for cardiovascular disease. And because of their advanced age, and therefore oftentimes they have multiple other medical problems, that makes their admissions more complicated and of longer duration. Atherosclerosis, which is heart artery disease, and heart attack were very much for the last 50 years the #1 contributors to disease burden, death and hospitalisation under the umbrella of cardiac disease. But nowadays we're seeing a significant uptrend in the contributions of other forms of cardiac disease besides heart artery disease, namely atrial fibrillation, which I'll talk about very soon, with a significant increase in the numbers of that, which is correlated to our ageing population. It's projected to increase by 60% over the next 15 years. And also heart failure. Now, heart failure, being a heart failure specialist, is very close to my heart, pardon the pun, but it already continues to be the leading cause of hospitalisations in Australia and has been for many, many years. And unfortunately, that trend does not look like it's reversing anytime soon. Cardiovascular disease also, not unexpectedly, contributes a significant cost burden to the Australian health system. Cardiovascular disease continues to be the most costly form of disease in Australia's health expenditure, and those costs are only projected to increase at this point in time, particularly with the ageing population and the ongoing cardiovascular disease epidemic. It's expected to lead to increases in expenditure in inpatient hospital services for several years to come. Thing we're really trying to focus on is controlling admission and readmission rates to try and cut down the amount of hospital costs. And that's where we're really focusing our attentions on trying to improve outpatient management and improve the transition from hospital to the community for patients. So we're preventing those readmissions. And this is just a nice sort of figure representation. This is the overall percentage to total expenditure contribution of a multitude of different forms of health burden, and you can see cardiovascular disease is quite clearly on top, with contributing well over 10% of the total health burden, so cost burden in disease in Australia. There's other impacts as well that I think people downplay, and it's what we see as cardiologists all the time, is the impact that having cardiovascular disease has on the person for the rest of their life. And it really does give a significant impact on a patient's general health and well-being, really limits quality of life, particularly after a significant event such as a large heart attack or the development of heart failure. A patient's ability to be physically active is significantly impacted on. it also can significantly impact from a mental health point of view and take a significant emotional toll on patients and their families, particularly as really significant cardiovascular events can lead to absenteeism from work, a loss of employment, an inability to return to work in the original capacity that they did prior to this event, and the subsequent stress that puts on family and finances after that. So as I said, one thing that I'm going to always lean back on throughout this entire talk is that a bulk of the risk associated with cardiovascular disease is strongly linked to risk factors that are very treatable and very modifiable. And as I'll show you in some statistics later on, where we're getting there, but we could do a lot better as far as aggressively managing these risk factors. So the usual group of them, which I'm sure you're all familiar with, that your GP probably pesters you to get checked every year, and you should. Cholesterol, blood pressure, diabetes or blood sugar control, body weight, and smoking. And another thing that's not often appreciated by patients is this process of developing plaques in heart arteries, or disease in heart arteries that contributes to heart attacks, really is not something that happens over a matter of weeks or months. It's a process that takes decades to occur. And we start to see the beginnings of this process as young as people in their 20s and 30s. So really honing in on education programs regarding healthy life choices need to not just be targeted at the older population that are succumbing to cardiovascular disease, but especially at younger populations, even as young as school age, to ingrain those ideas of healthy lifestyle, regular exercise, and good dietary choices from the beginning of life. So when I talk about cardiovascular disease, so as I said, this is pretty much an umbrella term that encompasses several different processes. The most common thing we see in cardiology is this process of what we call atherosclerosis, which long and the short of it is the formation of plaques or buildup of cholesterol deposits inside the vessels of the body. And that can manifest in several different ways. The way I see most commonly is coronary artery disease, where the arteries that supply the heart muscle have this process of deposits of cholesterol plaque building up in the arteries, leading to subsequent heart attack, or chronic stable angina, which is another common manifestation we see in the community. If that same process happens in the brain or the vessels that supply the brain, that can manifest as stroke. And also if that same process happens, particularly in the lower limbs, it is called what's called peripheral arterial disease. So effectively the same process of encroachment or narrowing of blood vessels by cholesterol plaque that compromise blood supply to the area that those vessels are trying to supply. And you develop significant symptoms, which, with coronary artery disease are things like shortness of breath and chest pain. With stroke, it could obviously, dependent on the area of the brain affected, be a multitude of different symptoms. And with peripheral arterial disease, it's leg pain on walking, or what we call claudication. Within cardiovascular disease as well, arrhythmia or heart rhythm issues are becoming a more and more predominant concern. And I could talk about them in themselves for an entire day. So to make it simple, I'll just touch on atrial fibrillation today, which is as common as anything and is contributing significantly to the health burden, as I mentioned before. Then heart failure. So heart failure is what I specialise in. There's a multitude of causes of heart failure. First of all, the atherosclerosis heart attacks can cause damage to heart muscle and can lead to the development of heart failure as a consequence of a heart attack. Or some patients have developed heart failure for a multitude of other reasons that are completely not due to the presence of heart artery disease at all. A lot of common things that we see are things like related to pregnancy complications, alcohol excess, chemotherapy, some chemotherapy drugs, substance use in the community, particularly methamphetamine and cocaine is one of the unfortunate reasons we see for heart failure in our young population nowadays. Genetic cardiomyopathies, other inherited conditions, and particular rare inflammatory conditions as well. Also within this heart failure group, people can develop abnormalities of the valves, which are the gateways inside the heart that effectively make sure blood goes the right way and not the wrong way. And valvular heart disease, again, can develop for a multitude of different reasons. Often it's due to wear and tear as people get older. But another unfortunately common scenario in Australia is the presence of rheumatic heart disease, which is the stiffening and hardening of valves as a consequence of a previous rheumatic fever infection usually in childhood. Now, this is not something we commonly see in the adult population in metropolitan and regional areas of Victoria, but Australia continues to have the highest rate of rheumatic heart disease in the world within our Indigenous population, which I think is still one of the greatest shames of all of our health statistics, when we see more rheumatic heart disease in the Northern Territory than we do in a lot of third world countries throughout the world. And then finally, also the development, one thing that's underappreciated is the development of dementia can also be contributed to by this same vessel disease, atherosclerosis, cholesterol plaque process. So what theoretically happens is that you develop these cholesterol plaques in the brain that often lead to a multitude of mini strokes or just starvation of blood flow to areas of the brain over time that can culminate in the development of a dementia syndrome, which we call vascular dementia. So this also sits within the realm of cardiovascular disease and can be an underappreciated long-term consequence of vascular disease. So I'll start by touching on coronary artery disease. Sorry, I'll just catch my slides up here. So 4% of Australians are currently living coronary artery disease. So I'm just going to focus on that, which is this process of cholesterol plaque in heart arteries. And it's particularly prevalent in older people. 18% of patients over the age of 85 have some form of heart artery disease. And as mentioned earlier, it's really the contributor to the leading cause of death in Australia. Deaths from coronary artery disease itself represent greater than 68,000 years of potential life lost in Australia, and that's 3-year-old data, so that number will have only increased. And a heart attack kills one person every 30 minutes, with 440 hospitalisations per day. So there's several terms that coronary artery disease gets referred to. Some people may have heard of IHD or ischemic heart disease. Some people have heard of CHD or coronary heart disease. But what it all comes down to is this graphic down on the right-hand side here, where you have over time, starting at the top right of this graphic, these formation of cholesterol plaques that deposit in the inner lining of the arteries that grow and progress over time. And there's a multitude of things that contribute to this process. Genetics does play a role, and that's something we're understanding more and more over time. But cholesterol profile, blood pressure, weight, blood sugar control, and smoking play a significant role in the development and acceleration of this process. And what can happen is these plaques can continue to build up till the point that they encroach blood flow so much that people start to develop angina or chest pain because they're not getting adequate enough blood flow past that blockage. Or these cholesterol plaques can also, can be very thin-walled and what we call unstable, and they can burst open and then have a clot form over them, which blocks the artery altogether, causing a very sudden, very severe heart attack, or what we call a STEMI, S-T-E-M-I. So coronary artery disease management is something that we do really well, but we can definitely do better. So the number one key, particularly in patients who present with an occluded artery or a heart attack, is getting that vessel open as quickly as possible. And this is either done by going to an angiography lab to get a stent, or by giving clot busting drugs if you live in a location where you cannot get a stent in a very quick period of time. We know that every second that an artery is blocked, heart muscle cells are lost and they do not regenerate, they die. So the time is of the essence could not be more applicable in this situation. And it's really important that both we are very well established at having the ambulance and emergency department services along with the cardiac services work in beautiful harmony with each other to ensure patients are getting the treatment quickly, but also educating the community about what symptoms they should be aware of and not ignoring chest pain and presenting to hospital without delay. We also, over time, have developed a significant understanding of medical therapy after the stent, after the opening of the artery, that contributes significantly to protecting a person long-term from this same process happening again. And though there's plenty of data there of what medications we should be using, there's still a significant variation in how well it's being used, particularly in regional hospitals and in different locations of hospitals or jurisdiction of hospitals. So comparing, for example, a large tertiary centre to a smaller regional centre. And at the moment, in most recent data that's a few years old, we're only getting about 60% of patients who are truly getting every single medication the guidelines would recommend they should. Also, another really important thing that to me is vitally important is after someone has a heart attack, is referring them to a cardiac rehabilitation program. We have excellent cardiac rehabilitation programs in Geelong. It sort of combines three things. One is social support, so patients spend time with other patients who've been through a similar event, and also a graduated exercise program and significant education on lifestyle choices to make and how to adjust their life now that they've had this happen to them. And unfortunately, again, access to this is varied across the country, and previous data have shown that across the board in Australia, only 30% of patients are accessing this incredible resource. But I do say, I don't have statistics for Geelong, but I know that our uptake is actually really excellent in Geelong, and we do have wonderful community programs that work well. Atrial fibrillation, I'll touch on briefly. So this is effectively an irregular heart rhythm that comes from the top chamber of the heart. Once people are over the age of 80, it's as common as the common cold, but we do see it in younger patients. And it's the most common cause of heart irregular rhythm in Australia. What we worry about most with atrial fibrillation is that it has a significant risk of developing subsequent consequences, the number one being stroke. So patients with AF on average have a 5 times higher increase of having stroke compared to those who don't have AF. And particularly they tend to often have more severe or catastrophic strokes as well. Also, patients with AF are more likely to develop heart failure as well. This is just the projected numbers of patients with atrial fibrillation, and as you can see, that's only increasing, and this is projected out to 2034, that the prevalence of AF is only going to increase, which is probably, we expect, culminated in multiple things, one being the ageing population, as I mentioned before, two being increased burden of cardiovascular disease, and also other risk factors that contribute to AF, especially obesity, alcohol excess, and sleep apnea is another common, untreated sleep apnea is another common contributor to this condition. So our two focuses for treating AF are stroke prevention is always number one. So back in the days, it was warfarin. I'm sure you've all heard of warfarin, or SAC as everyone likes to call it. But nowadays, we do have newer anticoagulants on the market that don't require the frequent blood testing that warfarin does. And they've made anticoagulant management much more manageable for patients, much more approachable, and have increased the uptake of numbers. But still, it's estimated only about 40 patients who should be on a blood thinner to prevent stroke are not. And this is something that we really need to address going forward. And as I mentioned before, it's also really important to not just treat the rhythm condition, but also treat the things that contribute, namely alcohol, sleep apnea, obesity, and also undiagnosed thyroid disease. Having an over or underactive thyroid can contribute to these heart rhythm issues. So on to my neck of the woods. Hopefully I won't talk too long about this. I could talk about this all day, but so this is some lovely data from the ACU of, they did a beautiful study in 2017 of a heart failure representation of how much of a burden it is in Australia. So a few numbers for you here. So 2.1% of Australians per year living with heart failure, or 67,000 new cases per year, with 1.1 million days of hospital stay, or 158,000 hospital admissions per year, which far outnumbers any condition of any other discipline of medicine or any other cardiac condition as well. There are 61,000 heart failure related deaths per year, 9,000 of which of those are within 1 year of a diagnosis of heart failure. It contributes $3.1 billion in healthcare per year as far as financial burden. So it's really contributing significantly across the board. And this is a nice little representation of us in Geelong. The number of heart failure cases in Geelong is considered to be higher on average than the rest of Australia, about 5 to 15% more than the national average. And that's certainly something that I see in my day-to-day practice. Here's a few statistics of Geelong and its heart failure numbers. Again, these are from 2017. So in that year, men by far outnumber women as far as all cases of heart failure. So 3,000 men, 1,600 women. You can see there that there's about 500 hospitalisations per gender and about 3,500 to 4,000 days of hospital stay. So on average, each heart failure admission is about 7 days in hospital for each patient, contributing a total healthcare cost in Geelong alone of $23 million combined. And the thing to appreciate with heart failure, as I touched on before, is that there is a multitude of reasons that heart failure can occur. Certainly heart artery disease, previous heart attacks leading to heart failure is still one of our #1 causes. It can affect anybody from the very young to the very elderly. A lot of my sickest patients are actually in their 20s, 30s and 40s. But I still have a lot of sick patients who are in their 80s and 90s as well. Once this diagnosis is made, it is a chronic lifelong condition. This is something that completely changes the outlook of a patient's life. It's a big adjustment for them to make, and it's a big transition and a lot for them to take in. And often, eventually, heart failure is a fatal disease that people succumb to. It's something they're on medications for the rest of their life for, so there's a significant cost burden for the patient there. It often impacts on their ability to continue to work. And oftentimes patients, if they are eligible, sometimes even need significant therapies as mechanical heart pumps or even a heart transplant to continue their lives, as their own heart can no longer keep up the work. As I mentioned, there's a significant hospitalisation burden and recurrent re-presentations to hospital, which is something that we've really honed our focus in Geelong over recent years. Among patients admitted to hospital with heart failure, about a quarter of them are readmitted or die within a month, and about 50% of them are readmitted within 6 months. So we have a lot of good evidence out there of how to treat heart failure medically, and we see really good success with aggressive treatment with a multitude of drugs. These patients go from often taking no medications at all to being on 6 or 7 medications a day. And so disease management plans for these patients are really vital, that can combine a multidisciplinary approach with a cardiologist, the patient's GP, often a nurse practitioner as well. And it's really important that we focus on making sure that patients are getting the most aggressive forms of therapy possible. So the newest drugs on the market in the biggest doses. There's a lot of lifestyle interventions that they need to learn about when they develop a diagnosis of heart failure that really change how their life is lived. So things like what exercise they can and can't do. They have to restrict their fluid intake for the rest of their life, because effectively they have a pump that can't pump properly. So they need to decrease the amount of work that pump has got to do. They have to almost omit salt from their diet altogether. They have to become vigilant in monitoring their weight every day. They have to abstain or at least significantly restrict alcohol consumption, and the list goes on and on. It's important too that a lot of these people, that we're not forgetting about controlling their other risk factors for cardiovascular disease, because that's oftentimes the reason they've developed heart failure in the process. And in some other instances, there is a particular, these are rarer, but there are particular causes of heart failure syndrome that have nothing to do with heart artery disease that do require their own specific treatment. The reason for why rehospitalizations are such a big problem in heart failure patients is there's usually a multitude of contributing factors. One is inadequately controlling the problem in the first admission, or not correcting the cause of heart failure. Not addressing other diseases that are affecting patients, so things like thyroid disease or kidney problems or lung disease that all contributes to stress on their heart. Another thing that we, I think, are getting really getting good at in Geelong is improving that transition between inpatient hospital stay and transition into the community. It's really like a huge leap for a patient who's had this new diagnosis. They've had the rug pulled out from under them. They get sort of thrown all of this education and support while they're in hospital. And then when they come to go home, it's a really big shift. And making sure patients are well supported with community nursing programs and outreach programs is very vitally important. And one thing we very much focus on in Geelong, and all heart failure programs are focusing on across Australia and the world, are ensuring that our follow-up of these very brittle patients is as timely as possible. I just wanted a couple of things to mention as well, as far as significant things in cardiovascular disease. I know I did give a talk recently on cardiovascular disease in men. There's no disputing that cardiovascular disease in men is still the #1 contributor to heart disease, to general health problems and death, but it's really underappreciated how much of an impact heart disease has in women. And one of the things that's most important, and there's a lot of public health campaigns behind this, is recognizing that women don't necessarily present men. So that textbook, read the elephant sitting on my chest, or I've got a belt tied around my chest pain, that is the telltale sign of heart attack that we all know about. At least 40% of women who are having heart attacks don't experience anything like this. I like to give one anecdote of a woman I looked after who had tooth pain when she walked, and went to her dentist, and her dentist said, your teeth are fine. She went back to her dentist a week later, my tooth still hurts, your teeth are fine. And went back a third time, the dentist pulled her tooth out and she was still getting pain. And she presented 2 days later to hospital with a heart attack. She'd been getting angina manifesting as tooth pain for about a month, and there really was nothing wrong with her tooth. So educating women about really being in tune with their bodies and raising the alarm if they're experiencing any symptoms that are out of the ordinary for them is extremely important. And then, as I touched on before, cardiovascular disease is a significant health burden throughout Australia, but especially in our Indigenous population. You can see that across the board, regardless of the age group there, that Indigenous Australians have a higher burden of cardiovascular disease than non-Indigenous Australians, even as young as patients in their late teens and 20s do start to develop issues at that point in time. So the next question is, where are we failing and what can we do? So I mentioned before about early age prevention and really honing in on those healthy lifestyle, healthy diet education programs as young as school age. This is something that needs to be ingrained in people from the beginning. So making healthy food more accessible and more affordable. And also weight control strategy should be part of every medical consultation. It's often neglected because it's something that is a bit of a taboo subject. We don't want to offend people, or we don't have time in some duration of GP consultations to touch on lifestyle choices, but something that's always should be kept at the fore. Promoting physical activity, reducing sedentary behaviour, again in children, especially with these ages of all of the screens that are available to young kids at the moment, continuing to drive in about a healthy, regular lifestyle, like the screen I'm talking to right now, is very, very important. And also, obviously, one thing that we've done extremely well in Australia is with smoking cessation, or discouraging the uptake of smoking through tobacco taxing, through packaging advertising. We've done very well with that. There's two sort of types of prevention with regards to cardiovascular disease, and what we really want to focus on is primary prevention, which is preventing the disease happening in the first place. But it's also very important, once someone has had this disease happen, that we address it from a secondary prevention point of view, which is reducing the impact or recurrence of that disease. So i.e. another heart attack or another admission to hospital once it's developed. So even though that stent's put in and your arteries opened up, the #1 thing that's going to bring a patient back to hospital with another heart attack is if they light up those smokes again, or they're not doing any regular exercise, or they're not taking the right medication, or their cholesterol's too high, and so on and so forth. I might skip over that bit. Yeah, this is just some statistics that I wanted to talk to you about. So you'll see on the sort of bottom half of this picture here about these 3 main targets as far as risk factors for cardiovascular disease: cholesterol, blood pressure, and type 2 diabetes. And this is again from my colleagues at the Baker, and represents truly how much more we need to do to ensure that people are getting adequately treated. So getting their blood pressure below the recommended target, getting their cholesterol below the recommended target, having their diabetes control reined in, or preventing diabetes altogether. And you can see that across the board, we're not doing as well as we'd like. And that's something that we really hone our focus on at this point in time. So just sort of finishing up here, I wanted to touch on, from a positive point of view, I know I've said a lot of negative things about cardiovascular disease. From a personal note, I came back from Canada, as Jack mentioned, 12 months ago, and have decided to lay my head in Geelong permanently. I trained here, and I'm very, very grateful for the exceptional training that I received in Geelong. I'm a country kid. I was born and raised in Violet Town, so I was never going to last in Melbourne for that long anyway. But we really are extremely lucky in Geelong to have such an incredible cardiac services program. We really offer everything bar transplantation of the heart. Everything else can be done here, whether it's heart rhythm problems, ablations, structural interventions to the heart, complex heart artery repair, cardiac surgery, and the treatment of advanced heart failure as well. So we really are very, very lucky down here in Geelong. Things that we focus on at the moment as far as cardiovascular disease management in Geelong, so really continuing to strengthen our outpatient services, and we provide several subspecialty clinics now, both in cardiac rhythm disorders and heart, which I run myself along with Professor John Amarino, who some of you may know. Trying to increase the capacity of our facilities, so more cath labs, more echo lab technicians, better equipment, newer technology, and also improving our community education and outreach programs. From a personal view, we've made several changes to the way heart failure is managed in Geelong. Particularly, we've redesigned the outpatient clinic model. So we now have a model where all patients who've been in hospital with heart failure are seen within 1 to 2 weeks post-discharge. To sort of catch them in that sort of danger zone area of where, if they're not transitioning well to home, we can pick up on things and sort things out before they land back in hospital again. We're also focusing on improving our patient education, both in inpatient and outpatient settings, and education of families, strengthening a co-management model with my colleagues at the Alfred, who look after the sickest heart failure patients in Victoria, but I now have a large chunk of patients who would usually have to go down the road to the Alfred to their management, who I'm quite comfortably managing here in Geelong to allow them to not have to travel so far. And I liaise with my colleagues at the Alfred frequently about these complex patients. And we're also working on developing better shared care models with GPs to improve our communication and individualised care plans for these very complex patients. So as far as our future directives, I'm just going to leave you with a few things. So prevention, 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 prevention. I can't say that any more frequently. Making sure that you have a good relationship with every patient has a good relationship with their GP or their cardiologist if they see a cardiologist, and having their modifiable risk factors checked at least every 12 months, if not more frequently. Good blood pressure control, good cholesterol control, and regular physical activity being extremely important. Everyone should exercise for 30 minutes every day. Daniel Andrews is letting the Melbourneites do an hour, so we should do an hour every day, to be honest. As far as our targets, sorry, I'm just going to move my screen here because I can't read that. Things that we're going to focus on, not just here in Geelong, but in a cardiac population as a whole in Australia. So research is something that has always been a strong focus and will become more and more of a strong focus with our wonderful new facilities being built here in Geelong. But researching both better treatment and better care for patients. Also identifying at-risk groups with genetic profiling. There's a lot of work that's being done on that to understand why some people, despite having all of their risk factors well controlled, still end up with cardiovascular disease, and genetics plays a huge role on that. Other things we can target is how we can regulate junk food or do similar sort of public health strategies to what worked with decreasing tobacco consumption. Improving remote monitoring, particularly for more isolated patients. Improving assessment of blood pressure. The development of stronger, more effective drug management, and increasing the availability through funding through the PBS for these new drugs, and public health education programs about how to make the right lifestyle choices. It's really important that we ensure that patients with cardiovascular disease get the services they need. So Chronic disease management programs are vitally important in these patients, as they often have a multitude of other medical conditions that need addressing. And patients with heart failure should always leave hospital with a nurse-led, cardiologist-supervised, multidisciplinary clinic follow-up plan, which is like the clinic that we run here in Geelong, which we already have seen from transitioning our clinic model here in Geelong. We're significantly readmission rates just by ramping up the intensity of how frequent people are followed up and sort of transitioning that time home a lot more smoothly. And then it's also important that patients are getting the best therapy. So aggressive blood pressure control, we know, is better controlled by allowing patients to have 24-hour blood pressure monitors performed rather than just getting one-off checks by the GP, making sure patients with AF are truly getting blood thinners if they should to prevent stroke, making sure that patients with heart failure are getting the medications that all of the international guidelines tell us they should get. They're all there. There's no reason why they shouldn't get them, and that they're getting followed up frequently in these clinics, that patients are getting access to the newest, most high-tech medications for cholesterol and diabetes, and that they're getting access to diabetic management specialist clinics, and also always recognising our those at greatest risk, our Indigenous population, patients with chronic inflammatory conditions, patients that live in rural and remote areas, and patients with mental illness. And then education is always important. So we've got to always help people as best they can to make the right choices. So that exists on a public policy scale, so with encouraging healthy eating and lifestyle. And as I said, I think that should start, and it already has started, with things like the life education van system that's been around since I was in high school, and I think before that, that educating kids on making the right choices in life from the beginning. Taxing trans fats and sugars, similar to what we did tobacco, and incentives to encourage people to eat well and to exercise. So that's, I know I've gone through a lot there, but the main things I wanted to drum home is that cardiovascular disease continues to be a significant contributor to hospitalisations and to costs within the inpatient hospital setting in Australia, but also it has a huge impact on how a person lives the rest of their life, and that our focus is obviously always on ensuring patients with cardiovascular disease get the best care, but we must never forget that a lot of this is preventable, and with aggressive attention both on a one-on-one between a doctor and patient and also in a public health forum, we can continue to make significant inroads like we have made in the last 50 years. Thank you very much.
That's fantastic. Thanks so much, Kate. Again, as you said, you addressed our men's health webinar a few weeks back, and that was brilliant, and you've outdone yourself again. Now, we do have a few questions, and if anyone does want to participate, if you can just click the button of raising your hand or through the chat line. Now, Helen has written in here, said she had an ECG a couple of years ago after a pain in the chest, which was abandoned due to the stress on her arthritic knee joints. There were no other tests done.
Right.
Technology advanced in this area.
Right. Okay. So I'm guessing that this meant that you had a stress test done. Probably, if you were having issues with your knee, you were probably unable to walk. Correct me if I'm wrong. So stress testing still plays a huge role in how we risk stratify or assess patients at risk. And there are two ways to assess patients for heart artery disease effectively. There are what we call functional tests, so where we're putting the heart under stress to see whether there's any signs of compromise to blood flow, and anatomical tests. So that used to be just an angiogram, which is an invasive test where we put catheters into the heart, inject dye and take pictures of the heart arteries. But nowadays we can also do CT scans of the heart arteries, which are non-invasive, much less risk associated with them, and still give us a very valuable piece of information in sort of lower risk patients. And then within the stress testing, traditionally stress testing is done with physical exercise such as treadmill or bike, which for some people isn't possible to be done due to orthopedic injuries, due to having amputations, so on and so forth. So there are several types of stress testing that can be done that do not involve exercise. They involve giving some form of drug to stimulate stimulate the heart and mimic exercise. So these can either be done through nuclear medicine. They're called a Pasantine thallium, or they can be done as a stress ultrasound of the heart, where we give a drug called dobutamine. And it's effectively trying to make the heart exercise without you getting off the bed. And we still get excellent reassuring results with these tests. And they do allow people to have some form of stress testing with it who wouldn't be able to participate in the exercise normally. And your GP can either refer you to a cardiologist to arrange one of these investigations, or they can order the thallium tests themselves still. There has been some change recently to the criteria for what GP tests can be ordered. I know that this stress ultrasounds of the heart can't be ordered anymore, but if you're concerned, you can always ask for a referral to one of the local cardiologists who can arrange one of those tests for you if your knee's a limiting factor.
We know we've got the great Sunrise Centre down at the Geelong Cat Stadium. That's for patients who've just gone through a coronary episode. And it's quite amazing to see people who've had a heart attack or had work done on their heart one day and they're on a treadmill the next. But we've got a question here that says, is there any other education program in Geelong area specifically for prevention of heart failure in those risk factors prior to an incident actually happening?
Yeah, that's a very good question. Most of that education process is more done by GPs at this point in time. There isn't a primary prevention forum, but that's something that I've realised is a paucity or a hole that we have. So stay tuned. That's something I would like to work on, especially I want to develop some form of public education with regards to heart failure prevention. So stay tuned. That's something we're working on at our end.
There's another question here, Kate. Do you consider low-dose aspirin to be one of those blood thinners for AF? Yeah, so that's a really good question. So several years ago, we were of the opinion that patients, to determine who needs a blood thinner for stroke prevention with AF, there's a scoring system that's made up of several things, including your age, your gender, whether you have high blood pressure, diabetes, and so on and so forth. Now, if you don't score high enough to warrant one of these stronger blood thinners, we used to think that aspirin was a reasonable prevention in those patients who didn't need a stronger blood thinner. There has been some recent trials comparing doing nothing to giving aspirin, and this is purely for stroke prevention, and it showed no difference. So at this point in time, in patients who purely have AF and don't have another reason to take aspirin, we are recommending that aspirin is not necessary and not beneficial in patients who don't meet criteria to need a stronger blood thinner. That being said, there's a lot of patients who fit into that criteria who need aspirin for another reason, such as they've had a stroke in the past or they have heart artery disease. So that doesn't mean that you should go off your aspirin, but for purely stroke prevention in AF, we don't use aspirin traditionally anymore. Look, we're just on 3 o'clock, so before I just hand back to Jack to thank you, Kate, I just want to remind everyone this is a legacy month. It's a full month of activities, and next week we're going to have a webinar on healthy ageing with Professor Julie Pascoe. We all want to know how to do that. The following Thursday, the 20th of August, we've got a webinar with 3 prominent clinicians from the Andrew Love Cancer Centre talking about cancer treatments and care. And on the 27th of August, we've got a webinar with Professor Peter Villeman talking about cutting-edge research and amazing clinical trials happening right here in Geelong. So if you want to be a part of that, you can go to our website, barwonhealthfoundation.org.au, or I will, given you've registered for this one, you will get an email just reminding you. So thanks for everyone for attending, and I'll hand over to Jack.
Thank you, Francis. Kate, this extraordinary ability to be able to communicate very, very complicated stuff to people like me. I do congratulate you. It's frightening. I think that we have a higher degree of heart issues in Geelong than we should have, and certainly higher than the population. I was interested in also the fact there's a gender difference, and I'd like to follow up on that later on, but you've certainly awakened us, I think, all to the various things we should be looking at. And I know that with my own community over the last few years, the number of my friends who have developed AF, you almost feel out of it if you haven't got it, I have to say. can I say thank you very much? That was absolutely fantastic, and it was well done. And just if I was one of your students, I'd be attending every lecture, I can tell you now. So thank you once again.
Thank you very much. And thank you to the Foundation for the opportunity. And thank you everyone for your time. I'm hoping that was beneficial and of interest.
Thanks so much, Kate. And thanks very much, Jack, for getting out of your hospital bed to help us today. And we will get to Jack and talk about One Health and all the fascinating information he's got about that. We'll do that next week. So for those who are interested, please tune in next Thursday. Thanks again for joining us.
Thank you.